Well, the first thing I think we need to fix is we need to stop whining as doctors. We need to stop complaining. We really do. There's so many things that are wrong. Part of it, it's our fault because we just let it go and we let it happen because we were busy taking care of our patients and we let other people start to manage healthcare.
Paging Dr. Cook. Paging Dr. Cook. Dr. Cook, you're wanted in the OR. Dr. Cook, you're wanted in the OR.
Welcome to the Prescription for Success podcast with your host, Dr. Randy Cook.
Hello, everyone, and welcome to the Prescription for Success podcast, a production of MD Coaches, a company dedicated to developing and empowering physicians and other healthcare professionals to realize a greater potential and to achieve a greater level of satisfaction in their chosen fields. You can find MD Coaches on the web at mymdcoaches.com. Well, we'll get into our interview in just a moment, but first I've got a message from Contract Diagnostics, a firm 100% dedicated to physician contract reviews. They offer a service that all physician families are bound to need at least once in their careers and possibly more. They've helped more than 10,000 physicians understand what they're signing and what they're risking for their family. All contracts are reviewed by an in-house attorney and presented back to you in language that you'll understand. They use custom documentation and compensation data, and to make it convenient, they deliver to you outside of normal business hours. Even if you have no need for contract review, they can simply advise you on the fairness of your current compensation structure or your contract renewal. All packages are flat priced, so you know what you pay up front. Residents and fellows can even make interest-free payments over time. So look them up at drpodcastnetwork.com/contract diagnostics or info@contractdiagnostics.com. You can also call at 888-574-5526. Well, my interview guest today is a pediatrician in Cleveland, Ohio, the city where she was born, raised, educated, and now practices as a pediatric sedation specialist. She is also the president and co-founder of Physicians for Patients, a grassroots organization that lobbies against the unsupervised practice of medicine by non-physicians. So now let's hear my interview with Dr. Nicole Johnson. And I am very happy today to be speaking with Dr. Nicole Johnson, who is up in Cleveland, Ohio. Nikki, it's great to have you on the program. Thanks for being here.
Oh, you're welcome. Thanks for having me. I'm very excited. Are you thawed out down there in Texas?
Not Texas, but Alabama.
That's right. You're in Alabama.
Yeah, and I'm happy to tell you that it did not get nearly as cold here as it did in Texas, but still we are very ready for the springtime here, and I bet you are up on the shores of Lake Erie as well.
Oh, yes.
So let's talk about you. What I like to do is begin at the beginning, and I think you are a truly unique guest for me. I think you're the only guest that I've had that is still in the place where you were born, and it looks like you've probably spent your entire life in Cleveland. Is that right?
That's correct. I grew up in a tiny, tiny suburb of Cleveland called East Cleveland, but pretty much I've been here my whole life. It's very close to the Cleveland city proper, and so some people find a hard time separating it. Mm-hmm. But yeah, it's its own little city. But yeah, same area.
So still extended family around for both you and your husband, or?
Yes, they are. The majority of my mom's family is here. My dad's family is pretty small, and there are just a couple of them still around. But yeah, for the most part, everybody's still here. I have an older brother who went off to the Marines back around Desert Storm time, and he and his wife just moved here from Colorado about 2 summers ago. And
Wow.
so everybody's here.
So the family's back home.
Yep.
That is so neat and so unusual in my experience, particularly among physicians. I don't know why physicians tend to get separated from their roots, but I think that's really fabulous, and I bet you like it as well.
Yeah.
But let's get on to the later stages of your life. Do you recall how old you were when you thought you might be interested in medicine?
I have to go back and do the math to see exactly how old I was, but I remember when the Cosby Show first came out. I
Wow.
Yeah, it was inspirational for me to see a Black couple on TV,
Of course.
professional, and Dr. Cliff Huxtable had his practice in his house. He was very relatable with his patients, and he really inspired me. And so I began thinking about it a lot more. The thought had always kind of popped in and out of my brain. I had a older stepsister with sickle cell disease, and I watched her suffer a lot in and out of the hospital.
Yeah.
And I always wanted to do something to help her, but I never knew what that would be. And until I started seeing that it was possible for me to be a physician watching Cliff Huxtable.
Yeah. That's very interesting. And gosh, I almost hate to bring up difficult topics at this stage of our conversation, but I am interested to know what, if any, impact the later troubles of Bill Cosby might have had on you, if
You know,
any.
it was very disappointing. I've always admired him, his character, his philanthropy, and his professionalism and dedication to his craft.
Right.
But you know, all of us are flawed. Every human is flawed,
For sure.
and it was definitely a huge surprise for me to
Yeah.
hear that it was him, but not so much a surprise from anyone being in Hollywood, just
Sure.
because, you know, sort of seems like it comes along a lot with the territory from what we're learning these days.
Yeah.
So it's very sad and disappointing, but not in any way. Well, I guess, you know, for us, for me, you know, I think as a community, it did hurt a lot. It's
Of
almost like
course.
an icon was, has, you know,
Yeah.
has gone for us.
But it also sounds like you had enough wisdom to separate Bill Cosby from Cliff Huxtable, right?
Yeah, I mean, and at this stage in my life, you know, in my 40s, you know, seeing that probably would have been different if I had known all of this in my 20s. So
Of course.
it's interesting. I don't know how I would have reacted back then. Yeah.
So when you got out of high school, you got into undergraduate school, you already had made the decision that medicine is where you were headed. Is that right?
Okay, so yes, I started out my freshman year thinking for sure I would go into medicine. And I started having conversations with people who were either interested in medicine or some of the people in the medical school who were graduates on campus in graduate housing.
Mm-hmm.
And I got kind of mixed thoughts about it. Lots of discussion about how difficult the path is. A lot of not so positive things and things that help that sort of kind of push down my confidence level that it was something that I could do.
Coming from other people who were interested in medicine or
Yeah,
completely
either
outside the
pursuing
picture?
the path or already, you know, in in that path period.
Mm-hmm. Mm-hmm.
But I didn't really have a ton of interaction with people who were in medical school and who were actually going through the training. And I still really didn't know how how, I actually, all of the details of how you get through medical school and what the training was
Right.
like. I didn't know that. So there was a lot of uncertainty. And the more I found out, the more I was just afraid of it. But the interesting thing was, and I changed my major a few times. I was always interested in the sciences and math, but as I became less secure in my ability, in my thought that I would pursue a path of medicine, I sort of decided that I would go and try to be an engineer. And for some odd reason, I picked electrical engineering, and I landed in the first one of the first courses, introductory courses, and I felt like I was in an entirely different world where they were speaking some foreign language that I had no clue.
I should think so.
And Yeah, but then I just had multiple moments throughout my undergraduate time where I would encounter different people along the way, other students, teachers, a stranger, and I would just hear the words, "You really should be a doctor." And it just kept happening.
Fabulous.
And I believed it truly was my calling. I just kept going back to the math and the sciences because that's what I enjoyed. And I could not see myself doing anything else. So, yeah. So then I went
Well,
ahead and applied, and I ended up applying to medical school at Case Western Reserve, which is the school right next door. I mean, I went to Case
right.
Western undergraduate, and I applied there. Early decision. I knew I wanted to stay local. I was a little intimidated about traveling for something away from my family, for what would be a difficult road, and where I would need a lot of support. And I had also met my husband, or well, the man who would be my husband already, and we were, talking about marriage. So I
Yeah,
did
well,
not
that
want to
always
leave
makes a
him.
difference.
Yep.
And what state was he also an undergraduate at Case with you?
Yes, he was. Yes, he's a year
And
ahead of me.
and what was his field of study?
So interesting. He was in accounting, and his parents were not very supportive of his college career. They did not. His
Hmm.
father was very much a civil servant, and he believed that that's what his son should do. He should become a police officer or join any one of the armed services. And so they were not very supportive of him at all, financially or anything in any way. So he stopped kind of middle of his junior year, and then ended up becoming a police officer.
Hmm.
And so, yep. And he has been on for 25 years now and hasn't
Wow.
gone back. Yep.
Well,
Yeah.
and I really want to make this interview about you, but
Hmm.
that's a fascinating story, and I'm wondering if he's been at it for 25 years nearly. Does he feel like he made the right decision? Is he still happy with his choice?
He does. He does,
Yeah.
because he's actually gone back to start taking some classes to finish and get his bachelor's degree,
Yeah.
and he's nowhere near accounting. So, yeah,
and how about you? Were you entirely supportive of his choice? I mean, that's kind of scary. The guy you're going to marry is going to be a
absolutely.
cop.
Yeah. Oh, it was very scary. I mean, for the city of Cleveland, of course, I was terrified, but I supported him along the way. I helped him study for his exam, his entrance exam. And
Wow, what a
yeah.
love story!
Hmm.
I love this.
Yeah. We met my freshman year in undergrad. So,
Well, so obviously you made it into medical school, and sounds like relatively uneventfully.
yes.
And when you got there, was it anything like what you expected, or were you totally kind of knocked off your feet? What was the mindset at that point?
Well, the fun thing is, Robert Wood Johnson Foundation had a summer program that they sponsored at Case Western, maybe a few other schools, but they had a lot of students who are minority students interested in a career in medicine come in the summer and spend 6 weeks at the medical school, taking some of the, kind of the intro classes and also shadowing an experience with established physicians in their practices. So it was very neat. And then we had a series of physicians who would come and speak to us about the career throughout that time period. And I learned a lot then. So it was very, I feel like I was prepared for what was to come. Once I experienced that, they also offered at Case, after that summer program was done, an introductory sort of summer course for anybody who was interested. And it was sort of some of the basic sciences kind of reviewed, some of the basic biochemistry, things like that, to kind of get you used to the rigor and the pace of things. So I actually felt ready. But yes, absolutely. The first few days in the class, biochem, my brain, I felt like it was going to explode. All the medical terminology was a completely different language. But I think I had a great class that we all were able to be pretty honest and open with each other, not a lot of competition. So we openly expressed our fears and anxieties together and helped each other study. So we didn't have that atmosphere where it felt so intimidating that we couldn't get through. We were, very supportive of one another. So I felt that, but yes, it was difficult. It was definitely a lot more difficult than I expected it to be. And I don't think you'll ever get to know that unless you're actually there doing it.
You're probably exactly right. And once you got the basic sciences behind you, did you have the feeling that, oh, well, now this is where I feel comfortable, I can handle this, or did you find it as intimidating as the basic science years?
I did what's called a primary care track that Case used to have, where we spent our first 2 years learning physical diagnosis and actually going into clinics with a pregnant woman, followed her through the obstetrics component of her experience. And then once the baby was born, we then became worked with the baby's pediatrician.
What a great idea.
So we started that from the beginning of our first year. So we got a lot of experience with the clerkship portion, but it was very different once I got to my third year. Third year for me was actually the most difficult.
Really?
And it was challenging because it was the time period where people were looking closely at me, at my performance, and making a judgment on how I would do. And it was dependent on the personnel who were on that particular rotation, which intern was there, which senior resident was there, which attending was there. And I had a difficult time with it. I actually struggled. I actually thought that I was, some of my rotations I did great with, but others surgery rotation, I was pretty intimidated, although I absolutely enjoyed my trauma rotations and burn unit rotation, and neurosurgery was awesome. But I felt like that was the time period where I started to doubt my capability, because I met with a few toxic personalities, but also it was me being self-reflective and just so hard on myself. I think that there was this expectation that you were supposed to be this perfect student and know everything. That was a period where I compared myself to other students a lot more. And it was tough. I struggled a little bit with depression then. And then I decided to take a break. I took a year off and
that's
decided
smart.
to come back to it. And it was actually one of the best things, the decisions that I made. And I looked internally. I reminded myself of all the reasons why I wanted to go into medicine, and I took the time to grow spiritually closer to God and find, my strength and figure out how to do it, because I knew I still couldn't see myself doing anything else. So I had to figure out how to get through it.
Was the medical school, were they supportive of that
Yes.
plan?
Yes, they were.
Good for
And
them.
when I came back my fourth year, I felt like a brand new person. I knew I could do it. My confidence level was sky high. And I was much more, I had a lot more clarity about my future, a lot more, confidence in my approach with every single rotation. I spoke up for myself, and it just went so much more smoothly. And I was
That is
able to
so
still
wise.
graduate the same year as my class, just a few months later.
Wow. That is just a tremendous amount of wisdom for a person in their 20s. And I remember my 20s, and I thought I was pretty smart by then. But the truth is that we're not, are we?
No.
We can be easily confused, and
Yeah.
and what a fabulous way to deal with it. I really got to give you high marks for that.
Remember medical school? You were confident, studious, hardworking, and you learned what to expect in all manner of patient care. Then reality struck. Regulations, expenses, staff management, and administration. Is this what we signed up for? Stress on the verge of burnout, no time for family, or the reason we got into medicine. Helping people. What are the options when you're afraid you're in the wrong career? Transition, teach, quit? What if there was another way? MD Coaches can help. We're a team of medical professionals with a century of experience in the clinical and business sides of medicine. More importantly, MD Coaches has been where you are, stressed and trying to navigate a world school didn't prepare us for. MD Coaches is your mentor, your confidant, to help you make your practice shine, navigate administrations, and successfully lead staff and projects. Or if you're ready to transition, we can help there too. MD Coaches is doctors helping doctors. Visit our website to receive a free, no-obligation consultation. Go to mymdcoaches.com/RX. That's mymdcoaches.com/RX. Isn't it time someone else was on your side? Don't let the business of being a doctor stop you from doing what you love. That site again, mymdcoaches.com/RX. Visit us today.
Physician Outlook is a new magazine platform built for physicians and by physicians, and it's designed to showcase unique physician talents. Sometimes it might be clinical talents, but mostly it's about the intersection between clinical and non-clinical talents, whether it be writing or painting or cooking, or maybe even making a political statement in front of a state and local governing body, or even at the nation's capital, and dozens of other things. It's available online and in print. It's visually stunning on all of its platforms. I promise it's really unique in terms of physician lifestyle magazines. I think you'll really enjoy it. We think it's just the thing to fill your prescription for success. And like the Prescription for Success podcast, Physician Outlook magazine amplifies the voice of any doctor who has something to say, and also uniquely engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get $20 off an annual subscription fee by visiting rxforsuccesspodcast.com/Physician Outlook. At what point did you think that pediatrics was going to be where you were headed?
So initially I thought I'd do primary care because I wanted to work in my community. I wanted to, do some sort of, family medicine or pediatrics and just take care of people in my community. We only had one community, family medicine clinic in the little small city that I grew up in. And I thought that was what I would do. But when I actually did my pediatrics rotation in my third year, the group that was actually on, a group of residents was on service that particular month were all IM Peds residents. And one of them was the chief resident for IMPs, and she was amazing. And I learned so much in that rotation. I had so much fun with the kids. And I actually happened to work with her again on internal medicine, this chief
Isn't it great
resident.
to have a hero?
Yeah. And I just fell in love with it. I fell in love with both internal medicine and peds. So that's why I ended up picking IM peds. I wanted 4 years of training also. I didn't feel like I could do and learn everything I needed to learn in 3 years. I'm one of those people I need to kind of see it a lot more often than just kind of cram it into 3 years because some bureaucrat somewhere says that it has to be 3 years. I needed more time, and especially for IMPs, you're trying to learn 2 specialties,
Sure.
in a 4 year time period. And I just had so many great teachers, and the environment where I trained and studied were just amazing and all inspirational. I constantly wanted to learn from them, and then become, teachers just like them.
And so from there, once you graduated, what was your postgraduate training like? I presume that it was also a mixture of internal medicine and peds.
Yes. So I did IMPs residency.
And does that lead to, so you do that, are you then eligible to take 2 different sets of boards, or is there
Yes.
board certification for an IMPs person?
No.
How does that work?
No, you're eligible to take both the internal medicine boards and both the general pediatrics boards.
And did you?
I decided to go into peds critical care. And so I never took my IM boards. I took my pediatrics boards. And I picked to do my pediatric boards first because that was the most difficult of the 2.
Sure.
And I figured I could do the medicine later, but I got involved into peds critical care so much that I just felt like, well, why even sit for a board? Why am I going to pay $2,000? And then MOC happened. And,
Right.
because I wasn't grandfathered in, that would be something else I would have to continue to pay for and keep up with in a field that I'm not going to be practicing in.
Right.
So I just decided that the smart thing to do was not to do that and not to take those boards. But I did. I do still kind of sort of keep up with the medicine. And in pediatric intensive care, we take care of adults. We take care of young adults. We take care of children with adult diseases. So I don't feel at all that my training was wasted. It was amazing. It was so well rounded. I
Yeah.
apply a lot of it daily, with my pediatric patients. We saw every place in the hospital. So I had that perspective coming into pediatrics. When I started as a first year fellow in the PICU, the nurses thought I was a second year fellow just because my level of confidence with sick people. Because as a senior resident on internal medicine, we were it. We did all the triage. We did all of the, we managed the codes and ran the codes and made all the decisions for the sick patients in the hospital. So we had to do that. A lot of general pediatrics residents don't allow that so much for the senior resident. So it was great experience, and my classmates were still great friends. There were 6 of us. And we bonded initially over email once we all knew we matched, and emailed each other to get to know each other's names. And then we talked about how nervous and we all were. And it was just an instant bond, and we still keep in touch with each other. And actually, we're planning a family vacation whenever the pandemic is over, for all of us to get together with our kids and everybody. So yeah.
So at that point, you were pretty much committed to a hospital-based practice, and you stayed right on with the faculty at Case. Is that the way it unfolded?
I did. There's actually there are 3 teaching hospitals in Cleveland. One is through the Cleveland Clinic, and one is Metro Health Medical Centers, the county hospital. That's where I did my training, my internal medicine and pediatrics residency. And then I did my fellowship at Rainbow Babies and Children's, which is where I am right now. So I've been at all 3 of these teaching hospitals, and they're all affiliated with Case. So So either place I work in Cleveland, if I want to stay in academics, it's going to be on faculty as Case Western.
Right.
So, yep.
Well, now let's talk about one other thing. The specialty of procedural sedation
Yes.
is something that a few, probably many of my listeners are not going to be familiar with. Believe me, during my time in practice, I never heard of such. So do tell us, what does a procedural sedation specialist do, and why is there a need for it?
So for pediatrics, the need is much greater than for adults, although the adult field is sort of growing a little bit too. We are basically anesthesiologists outside of the operating room.
Right.
And we don't, and we do that with a natural airway. So everything procedure that a child would need to get through, hold still, relieve anxiety, not experience pain, any procedure of that kind, we sedate for.
What a great
So,
idea.
Yeah.
So I bet there's not a papoose board anywhere in your hospital.
There is a papoose board somewhere in our hospital. Unfortunately, the dentists are using it, but on some of their kids who what they provide with sort of a small dose of oral medication. So we don't tell the child life representative that though. But we actually do sedate for a lot of the dental patients as well. If they fail nitrous oxide or a small dose of Versed to try and wiggle a tooth out, then they're pretty much coming to us. And so, right. And we have our own child life specialist, and our unit is actually pretty unique. We're one of the first in the nation. And we
really?
Are primary.
For procedural sedation.
Yep. For pediatrics, for sure. And we're a founding member of the Society for Pediatric Sedation. And so that organization helps us, set the standards and goals for safe pediatric sedation throughout the country, but we have some international interest as well. And we teach instructional courses, simulation based, on how to do it properly and safely, because it is actually a growing field. It is a growing requirement for physicians who work inside of hospitals with children to get to sedate them. So we want to make sure everybody's doing it correctly and safely. So our unit is a unit all by itself. I have my own nursing staff, and we're all dedicated just to sedation. And my colleagues, physician colleagues, are all pediatric intensivists. At our institution, I have one who's an emergency medicine doc who was was sort of strong-armed into doing it many years ago, and still enjoys it because the emergency medicine docs still do procedural sedation in the ER also. So he comes and hangs out with us a couple of times a month, and it is so rewarding.
So if a child is going to need a bone marrow biopsy or a lumbar puncture or anything, and in order to do that, do they sort of have to schedule with your department just as if they were getting on the OR schedule, or how does that work? It's not like they can just call you up and you show up, right?
Correct. No. We have a schedule. We have we operate 2 physician teams per day, and we schedule ahead of time. We do have a couple of add-on, slots per day for urgent cases, but predominantly our patients are all scheduled. About 90% of them come from the outpatient setting, 10% from the inpatient setting. We screen all of them first. So at the time that we are requested, we go through and review their medical history, and occasionally we'll get to examine them, in person, but nowadays not as much just because of COVID. And if they meet all of our criteria, then we get them on our schedule and prepare them for the day. If they do not meet our criteria, then we have the ability to refer directly to our pediatric anesthesia colleagues. Our anesthesia colleagues only have one anesthesiologist working outside of the OR per day. So they're super busy. So they don't have the room for a lot of add-ons as we do. So that's where we get our business from, because we're doing things outside of the OR, and because they don't physically have that space and or the numbers to the staffing to be able to do it. So
well, that may be the answer to my very next question. And I can't restrain myself from getting into the troublemaker areas sometimes. But one of the things that popped into my head was, if you guys are doing these things, have you ever had any pushback from the anesthesia department, or are they grateful to have you, or what's the climate of opinion there?
That's a great question. It's so variable throughout all of the hospital systems. At our institution, though, because we started it, we actually, our division chief over kind of like 40 years ago, when this started, was also the chair of pediatrics. And we recognized that there was a huge backlog of children who needed MRIs. And they were just sitting around waiting, and a lot of them needed to be sedated for it. And anesthesia did not have the ability to keep up. And he presented, the chief of the division presented a business plan to the administrators and said, we can do this in a more cost-effective way, and we can get these kids scheduled and done. And that is how it has always worked. The American Society of Anesthesiology does not give up the kind of ownership and control of any type of procedural sedation. So nationally, they have oversight over any type of sedation that happens out in any health system. So we do have anesthesia oversight, but in our institution, that sort of really means that, hey, we just tell you what our outcomes are every month or every quarter, and just kind of let you know how we're doing, and then you go about your business and we go about ours. And so that's how it works. No pushback at all. Actually, we get more. Can't this patient go through the sedation unit than anything? So
that's quite a success story. So congratulations for that. Well, before we completely run out of time here, one of the things that I'd like to get to, I know that you're quite an activist, which is a good thing. I think we could use some more activism amongst ourselves. So tell us, if you will, a little bit about what you're passionate about. What are the things that you think we need to fix, and some of the ideas about how we're going to fix it.
Well, the first thing I think we need to fix is we need to stop whining as doctors. We need to stop complaining. We really do.
Goodness.
There's so many things that are wrong. Part of it's our fault because we just let it go and we let it happen because we were busy taking care of our patients, and we let other people start to manage healthcare. And so we need to, instead of sitting back and whining and complaining, we need to be solution oriented and organized and actually get things done. We need to get ourselves involved with legislation, with policy. And so this is how I got into it. I started on Facebook in a lot of physician groups, and all I heard was just complaint. And I asked, is anybody doing anything? Why are we here complaining in this secret group on Facebook? And there were already a couple of grassroots organizations that were just starting to build. And so I started connecting with other physicians who were actually out doing things. And the area that really caught my eye and my concern was the story of a fellow physician who was misdiagnosed by someone who wasn't a physician but claimed to have physician oversight. It was either a nurse practitioner or a physician assistant, and she was a resident at the time in a urology program, and she ended up having a disseminated fungal infection. that was pretty much kind of blown off almost and completely misdiagnosed. And so this lost her her residency, cost her her residency, and has affected her life completely.
Yeah.
And she started to look into this phenomenon that was going on around the country where nurses were lobbying to gain what they call full practice authority, which is basically unsupervised practice. And to us, it seems like that's medicine. You're at this point, you've crossed the line from practicing advanced nursing to now you are practicing medicine in a way where there's no physician oversight. And we found that to be dangerous. And so that really we started getting flooded with people. Once she started coming out about this, a lot of people started flooding the feeds with stories of what is happening with their patients that were referred to them or patients they referred out who ended up seeing either a PA or not, or a nurse practitioner. And then people were hearing, seeing posts from nurse practitioners on social media asking for help with things that we thought were very basic things that a physician would know. And our alarm levels just continued to grow. Then we discovered that a portion of the Affordable Care Act was actually a driving force behind this growing phenomenon. It pushed for more non-physician practitioners to be able to serve independently from physicians in order to cover access for the expanding insurance covered population that the ACA afforded. So they didn't have a plan in that bill to increase the physician workforce. It was only the nursing non-physician workforce that was in that bill. And we started seeing the numbers of these online schools, quick turnover of nurse practitioner certificates, where from 2015 to 2016, those certificates doubled compared to previous years.
I had no idea the numbers were that profound.
Yes. And then in a wake of a nursing shortage and a physician access shortage, this was sort of it driving in every single state to legislate these types of nurses to actually provide medicine, or access to care outside of, physician supervision. And then then the AMA sort of started getting involved with it too. And they had a tracker and they looked at, whatever the states that actually were allowing this to happen, where exactly were these nurses practicing? They were predominantly practicing in the exact same places where physicians were already practicing. They were not covering areas with low access, like the rural communities. So we were, all of that information combined with the danger of it to patients, that got us active. And we started a few different groups. Now there's two, one a little larger than ours. But the two groups sort of have a different focus and how they interact. Our group is more focused, our group Physicians for Patients, or Physicians for the Protection of Patients is the longer name. We focus on ways that we can improve the physician and increase the physician workforce. And the other group, focuses more on lobbying against the growing path to complete 50 state, legislated nurses practicing without supervision. So we organize, we make phone calls, we write letters. This has led me to speak at the Library of Congress on this topic. A part of the Free to Care organization. And you interviewed Dr. Marion Moss, who's one of my inspirations and one of my mentors. She is one of the people who got me started with this. And so she's helped to organize this large organization called Free to Care. And it's made up of a lot of doctors, physician or grassroots organizations, and other patient-led organizations as well. And so our overarching goal is to lower the cost of healthcare, restore the physician-patient relationship as the center of it all, and to provide all of our patients with quality medical care. And that's just, I kind of just, that's just the summary of it. And then all of our groups combined are working together to achieve that goal.
So, what's the prognosis, do you think? I mean, this you really got to have your head in the sand if you don't see the significant proliferation of exactly this phenomenon. And can that genie be put back in the bottle? What do you think?
What I find very interesting is the way that the Trump administration handled the pandemic was a lot of deregulation.
Mm-hmm.
We saw telemedicine boom. We saw more rapid approval of medications and treatments and vaccines, and doctors being able to practice more freely. Also, with some of the deregulation, to be able to give patients a lot more access, and I think that is a huge part of the answer. However, now with the new administration, more regulations are being tacked on. If physicians can all get together and see what are the real problems that are driving
Right.
our problems in healthcare, skyrocketing costs and lack of access, disparities in care, then I think we will be able to fix this. But it's a long road. It's going to be difficult, and we
Yeah.
really need to be engaged. And so I really hope that more people are awake because of this, because of the pandemic. For me,
Sure.
that's a silver lining out of this is that regulations make it harder for you, to practice your craft and be a doctor. Sure, they just the insurance approval, pre-approval for
Mm-hmm.
procedures for medications when that was suspended during the pandemic. It freed us up back to
Yeah.
being the doctor and the patient and being able to make that decision together. And I really hope enough people see that and we start to work together.
And just to be perfectly clear, I'm pretty sure I understand what you're saying, and correct me if I'm wrong, but it sounds like you're not trying to, and really nobody with any kind of reasonableness about them would be objectionable to a true physician extender. But for
Correct.
someone who is not a physician to be practicing with no oversight whatsoever is the big objection. Am I correct about that?
Yes, that is the objection. I work with nurse practitioners and physician assistants every day. There are some brilliant ones that I would love to continue having, to work with. And I think they are a major asset to our medical team. But they're just not educated the way that physicians are. And to be able to be practicing the way physicians do is just unsafe for patients. And I've known several nurse practitioners, CRNAs, physician assistants who've gone on to become physicians, and the resounding common sentiment from them is that, wow, I really didn't know that I was missing this much education
Yeah.
in what I was trained in. And those are the people's voices that I really want to hear, that we really need to hear from, because the nursing lobby is really pushing this information. The people who are going to become nurse practitioners and out there doing this are doing this for a good reason. They feel like they are serving a purpose and they feel like they are doing something great for healthcare. And it's not them that are pushing this message that they do the exact same thing that doctors do. It is the lobbying industry, the bureaucrats on top of, and the nursing leadership that's
Mm-hmm.
pushing this. And it's also driving nurses away from from the bedside,
From the
where
bedside.
we
Exactly.
desperately need them.
Yeah.
The turnover in our ICU right now, just from nurses going, straight from nursing school, work a few months as a nurse in the ICU, and then they go on to become a nurse practitioner somewhere. It's astounding. It actually is one of the reasons why I left the ICU and really, solely focused on pediatric procedural sedation, because the turnover was so great that I think that the risk to patients is high, just because we don't have that dedicated nursing staff anymore. And we need that. Patients are suffering, and nurses are suffering from the higher staffing ratios.
Yep.
They're having to care for a lot more patients than they once did at a time. And it's not safe. So,
well, it certainly is a truly worthy cause, Nikki, and I wish you great success in the struggle, because it's going to be a tough one for sure, but
absolutely.
Sounds like you're up to the task. That said, we are at the part of the program that is my favorite, and that's when I'm going to turn the mic over to you and let you tell us how to be successful. So I will sit quietly, and Dr. Nicole Johnson, please give us your prescriptions for success.
Okay, dear younger Nikki, practicing medicine is not only your calling, but it is an honor and a privilege of lifelong learning of the human condition. You will care for people in their most vulnerable states. They will share with you things they've never shared with others. You will be with them as they experience things they've never experienced. Learning to practice medicine will be challenging to every part of you, physical, mental, emotional, and spiritual. But you really do have all of the tools you need to be successful. It's a doctorate, and it's people's lives at stake. So don't get discouraged when it gets tough. It's supposed to be. God and family are your joy and your refuge, and they will all be there with you when you need them the most. Success is achieving your goals without sacrificing the things that matter. Remember these three things as a prescription for your success. 1, it is impossible to be perfect, so don't work on your weaknesses. Work on your strengths, because someone else's strength is your weakness, and you cannot be successful without collaboration. Number 2, always anticipate the worst case scenario. Do what you can to prevent it, but be prepared to manage it if it arrives. And number 3, talk to successful people. Learn their prescriptions for a success. They all started where you started, and most people are very eager to tell their story and want to help you succeed. Do all of that. That is your RX for success.
Well, Dr. Nixie Johnson, thank you so much for sharing that wisdom with us. And there is a lot of wisdom there, and a lot of wisdom from what we've heard from you today. This has been a fascinating career that you've shared with us. So thank you for that. Before we close out for the day, I want to give you an opportunity to let our listeners know where they can find you, how they can get in touch or get involved with some of your causes, and anything else that you'd like to share. So email addresses, websites, whatever you have, please let us know right now.
Okay. Our website for Physicians for Patients is physiciansforpatientsofficial.org. And that will connect you to all of our social media links. It will also connect you to the Free to Care organization that we are members of, and tell you a lot more information about us and how to join. I am on Twitter as Not a Provider MD. And that's me, my smiling face there. I'm pretty active, engaged, as you like. Thank you, Randy, so much for having me. I had a blast.
It's been a lot of fun, and I love that Not a Provider handle.
Oh yeah. Oh yeah. We didn't even talk about that.
When my hospital began to reprint the order sheets, and the home nursing agencies were reprinting their order sheets, and down at the bottom it said provider. And I thought, well, it's just kind of time for me to move along.
Yeah.
So,
Yeah.
But it sounds like that you're going to provide some hope for those who will be continuing the battle, and I congratulate you for that. And I thank you for that. And once again, thank you so much for joining us on Prescription for Success.
Thank you.
Well, I do hope you enjoyed my conversation today with Dr. Nikki Johnson, brought to you by Contract Diagnostics, a company specializing in contract reviews. Specialization is certainly something we can all appreciate. So when you or your family have contract needs, please give them a call at 888-574-5526 or find them at drpodcastnetwork.com/contract diagnostics. And that'll be a wrap for another episode of Prescription for Success. Before we go, I want to encourage you to become a subscriber. Also, look for even more information about our guests in the show notes, which you can find at rxforsuccesspodcast.com. We look forward to your comments, and we hope we earned a 5-star rating today. And finally, please consider becoming a patron. Just visit patreon.com/RX for Success podcast. Thank you so very much for listening today, and don't forget to fill your prescription for success with my next episode.